Hello, good morning. I'm Ashok Rokade, consultant rhinologist and Skull Base surgeon from Winchester and the University Hospital Southampton, UK. I welcome colleagues from around the world on behalf of organizing team to this inaugural Winter Global Rhinology Endoscopic Sinus and Skull Base Surgery Webathon. Global Rhinology Network is a registered non-profit organization with a mission to foster surgical education in rhinology and skull base surgery. We have successfully hosted annual multi-center live surgical webcast, the LIONESS, since 2014 in collaboration with Lion Foundation. Thousands of surgeons from all corners of the world have benefited from it. More than 2,000 surgeons from 110 countries have registered for GRACE 2020. We will have hugely informative and engaging sessions presented by eminent rhinologists and skull base surgeons from around the world. GRACE 2020 is hosted at the Global Telemedicine Studio of Professor Wilko Grolman in Utrecht in Netherlands. It is supported by Medtronic and Karl Storz. Thank you.
The head and neck surgeries you perform are vital. Your patients place their trust in you. You help them continue to speak and smile, eat and drink, hear and comfort. You're committed to helping them continue to live fully, to feel deeply, and to enjoy the quality of life they've come to expect. That means being confident that you're protecting and preserving your patient's head and neck nerve function during procedures. Introducing NIM Vital, the next generation of nerve monitoring technology. NIM Vital provides advanced nerve monitoring that helps you reduce the risk of nerve damage during head and neck procedures. Detailed intraoperative nerve condition information helps inspire your surgical strategy. An intuitive user interface with a wire-free patient interface allows for easy setup and enhanced visualization from the surgical field. Real-time notifications of nerve conditions, visually and audibly. Green, yellow, and red status bars provide visual information, and their associated tones provide audible cues, making monitoring function easier than ever. NIM Nerve Trend EMG reporting enables nerve condition tracking throughout a procedure, even when using intermittent nerve monitoring. And when paired with a NIM continuous monitoring electrode, you have continuous nerve monitoring informing your surgical strategy. NIM Vital pushes the boundaries of monitoring nerve function in various procedures in head and neck surgery, with real-time information available during surgery, giving you confidence in nerve function. Because protecting patients' nerves and senses is more than vital. NIM Vital.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients? with technology customized to your unique clinical and facility needs. Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
Hello?
So, hello, thank you. Yeah, I think our next speaker will be Mr. Elgan Davies. Sorry, we missed the talk in the morning. So he has very kindly joined to deliver the talk now. And one of the very key important talks about surgical technology, how best to use the surgical equipments that we have to our advantage. So Elgan does this on our Wessex FES course, and the delegates have always found the talk very, very useful. So before further ado, can I invite Elgan?
Thank you, Ashok and team, for inviting me. Hopefully the sound is working properly. This talk is, as Ashok said, a lot of it is aimed for beginners in powered instrument sinus surgery. However, whenever we do present it, it's interesting how many senior surgeons say, I've never thought of that one. I live and work in the northwest of England, south of Manchester. Nearest town is Crewe, famous for making most of the steam trains in the world in its day, and now famous for making a rather better product. Our tools of the trade, obviously cold steel, powered instrumentation is what I'm going to concentrate on today, with microdebrider, blades, drills, and how we're going to use those most effectively to help our surgery. This is the range of kit, and we have to work out how we get all this in and around the patient and use it properly, from consoles, foot pedals, handpieces, video stacks, and whatever. And it's important to set everything up ergonomically so that every piece of the instrumentation is where you want it, whether you're standing surgeon, sitting surgeon, how you relate to the anesthetic machine, the scrub nurse, where all the tools are, in addition to all the settings, so that you don't get all your cables and wires mixed up. So we need to know all features of these items, and as the surgeon in charge of the case, you've got to be aware of all the parameters you can change. It's no one else's responsibility. Handpieces through the years have gone through a range of names according to their ability and torque and different motors. Currently ending up with the M5 handpiece that we commonly use for our frontal sinus and skull base surgery, because it allows use of these grey hub 30K burrs. We need to know how the foot pedal works. So many juniors do not know what these 3 different pedals do. They know this one, which is like the accelerator pedal in the car, but they don't understand the nuances of the other ones. Ergonomics. I spend a lot of time teaching the juniors how to keep these cables and wires out of the way so they don't tangle with each other. So I always have my video leads attached to the top of the table here, and the powered instrumentation is attached approximately at the level of the umbilical. So my left hand is controlling the camera and the right hand controlling the instrument as a right-handed surgeon. Very important for beginners to know the difference between these different blades. You can see some of them have white plastic, Some of them have blue plastic hubs. And the difference is they have a maximum speed of rotation within the instrument. So the standard blades, we used to say 6,000 RPM, they're now recognized to manage 7,500 RPM. The blue hubs are the HS or high-speed burrs. These are the drills, DCR burrs, etc., which work at 12,000 RPM. And the grey ones are the 30K, which go up to 30,000. The reason you need to know this is if you put a white hubbed plastic blade in the handpiece and you run it at 12,000 RPM for more than 5 minutes, it's quite possible this plastic will melt and you need 4,000 to 5,000 euros for a new handpiece. So you've got to use the right settings for the right blades. The blade design, again for the juniors, there's only part of the blade which is open at any one time, which means there's a closed part you can use to protect structures like the skull base and the orbital wall. So you use that for your own advantage. We've got real-time suction to keep debris out of the way, and the blades will cut tissue rather than tear. So in terms of the instrument itself, as the surgeon, same as if you're doing ear surgery, you've got to choose the burr, you've got to choose the direction of rotation, you've got to choose the speed. Important, one thing you don't think about until after a while is if you are rotating slowly, the suction port is open for a relatively longer period of time, so you take in larger pieces of tissue. This is great for nasal polyps, but maybe not so good for vascular structures. So, but if you're frustrated and something's not working, you think, oh, I need to go faster. Well, when it's faster, you will actually take out smaller pieces, and it may be an inverse relationship to what you anticipate. As we said, the powered blade is dissecting in a plane parallel to the skull base and lamina rather than at an angle to it, so you can use that for safety. These are my starting parameter guidelines for the juniors. We may well be using soft tissue oscillating 2,000 RPM for nasal polyps. More vascular structures, we might want smaller pieces of tissue. And for bone, we probably want faster, more akin to a drill. Remember, when you switch the console on, the default parameters will come up as 5,000 RPM and 12,000 RPM. So if you start off with a white hub tri-cut blade, you will have to change the settings. So here you can see on the left, the default settings, when you switch it on, 5,000 RPM. I'll point out the irrigation here on the pump. 5 mils is not enough. You need this up at 25 or 30 mils per minute, as I've done on this central photograph. So we change 5,000 to 6,000 for the one direction, 30 mils of fluid. If we're on skull base on the right hand, we use 30,000 RPM, again with more irrigation. This shows you the typical settings and how you might want to change it. You can alter with the top left, top right. So default has to go down to 5,000 or 6,000 RPM, particularly if you're using this white hubbed plastic blade to start. So you must correlate the two together. Choose instruments which fit the anatomy. There's a vast range available now, and these are all 30K drilling burrs for the skull base. If you're going to be doing frontal sinus surgery, to match the instruments, consider using an endoscope. If you're right-handed like me, you want to be using a 45-degree scope with the FLA annotation, so the light post does not foul the anesthetic tube. An important point. Again, general principle, it's akin to ear surgery, nose surgery, any surgery. A large diamond burr is probably safer than a small cutting burr. You're not going to make the pinhole in the skull base as easily. How do you hold the handpiece? This shows you the correct way of holding it from the brochure. It's very much a pistol grip, like a pencil. You want a full range of wrist movement in your operating hand. When we teach on the cadaver courses and anatomy and surgical anatomy, it's not uncommon to find people holding the instruments. It varies a lot actually from country to country, but some people hold it like this. This is what I would call the screwdriver grip. This will be the javelin thrower or the stabber. A common problem, people hold the handpiece too far down, hold the shaft too far down. Their finger and thumb have got to be on this collar at the front to give you that fine fingertip control. So you've got to be able to hold the instrument exactly the same as you would be holding a pen to write or sign your name. Otherwise you won't have fine control. So if you think about it, with a full range of wrist movement, can you sign your name like this? No, I can't. Can you sign your name with that power smash tennis grip? Not at all. Can you sign your name this way with a javelin thrower? No. You've got to be holding it like this to be able to sign properly with delicate movements. So again, note that the position of the suction tubing, if you're right-handed, the suction tubing has to go on the opposite. It's not on this side, it's on the contralateral side where you can't see it, so that your thumb isn't obscured by it. Again, to show you that position of the suction tubing, it comes out at 6 o'clock. If you're right-handed like me, this will come down that side of the instrument. If you're left-handed, that suction tubing has to go the other side. Invariably, the scrub nurses will just assemble it. You may find that the irrigation port is coming out here at 9 o'clock and the suction tubing is on the other side. So you have to change it so it's comfortable. Another little point, underneath the instrument, there's a locking button here with the arrow. This, when it's locked, does not allow rotation of the blade with the thumb screw. You have to unlock it for that to happen. Personally, I find it easier to pronate and supinate than to use that wheel. Another important thing you've got to know, suction pressure. Many operating rooms, we have these with 2 suction devices attached to the stand. There are some where there are 4 or even more suctions, and unless you've got all that working properly, you'll find one bottle stealing suction from the other. Therefore, I have one suction attached to the powered instrument, usually this one from the anesthetic machine, and then the anaesthetist's got a close watch on what's happening on the volume measurements. Not that we ever use 2 litres unless there's a major issue. And the other one may be used for normal suction, the normal phase suction. So consider using 2 machines rather than having 2 things attached to the same machine. Less likely to have a problem. What do most people not know? What is the suction pressure you need for the blade to work properly? Use 180 millimeters of mercury. That's a problem if it's not happening. So here's back to our instruments and the handpiece and the foot pedal. So again, what does this do? I think most of us know that the foot pedal is like what happens in the car. The faster you press it, the faster it goes. This is the one that changes the direction. You can see on the left side, it changes between oscillating and unidirectional. So important to know, top left button. This is an important button again for those starting out in surgery, the delta sign, the delta button. What does that do? Well, look closely at the tip of the blade. You'll see that it opens it so that your blade can be open or closed on insertion. If it's open on insertion, you are much more likely to snag the inferior turbinate and cause bleeding that gets in the way. Now we're moving into the current era as someone who recently had a screening swab positive in my hospital with no symptoms at all and 10 days at home. It's quite important to discuss these items. We know that COVID is important for droplet spread, aerosol spread, and airborne spread. In reality, we probably can't differentiate much between these. We've pontificated about it for long enough. But back in May and June, when we were in lockdown, along with my colleagues Sam Leong, Dilesh, and Peter Andrews, we arranged a study in Liverpool and set up a lab simulation of powered instruments to see what happens with droplet spread during our sinus surgery, the way we do it. the measurements, we used fluorescein in our irrigation fluid, and then we could map the fluorescein and droplets on a grid pattern outside the model. We used fluorescein impregnated tissue, in this case, white grapes that had been soaked and injected in fluorescein to simulate nasal polyps, and see what happens when we're operating. Sorry, going backwards, I'm meaning to go forwards. Go forwards again to those. So this was our lab setup. With the microdebrider, we found there was a small amount of droplet spread on the left. This is for a right-handed surgeon standing on the right side of the patient. You can see the yellow marks show us a small amount of contamination and a moderate amount of contamination in this area. What happens with a diamond burr? So we're now putting on a 30K diamond burr. This is the pattern of spread in that situation. So again, more contamination in these zones. And with a cutting burr, exactly the same. At no point in these studies was the burr used in a powered mode outside the patient's head. So it's all within the nasal cavities. This is the droplet spread we're getting with our standard settings. So what did we conclude? The parameters are obviously very important. You've got to work out, well, firstly, you've got to check the suction vacuum pressure is adequate to remove fluid from the tip of the blade. So you've got to have 180 millimeters of mercury at least. What's the rate of irrigation? Yes, if you've got too much irrigation and the suction can't cope, it's common sense that you're going to get droplets and fluid dispersal. When you take the instrument out of the nose, either to change the blade or to do something, do not use the foot pedal, because that's where you will get aerosol and droplet spread again. This ties in with if there is a blockage and the scrub nurse needs to remove debris from the tip, take care with the stylet. You can imagine that little bottle brush being pulled in and out of the tip of the blade is going to be a beautiful way of spreading droplets. Most importantly, if you're using a drill, the single biggest thing we found was you need a third hand for suction constantly while you're drilling, and that reduces the droplet spread. So a good indication for three-hand technique, any drilling in the nose. So hopefully that's given you a little more insight, both for beginners and maybe for more senior surgeons. How are you going to use these instruments to help you do the surgery? How are you going to use them optimally and safely? But most importantly, think about the settings you're going to use. Because if you start doing this properly, you will improve your surgical efficiency no end and keep yourself away from the sharks. Thank you.
Thank you, Elgan. That was excellent. I think often we tend to ignore the nuances of the kit and the help that can provide. So very well presented, and hugely appreciate, as always.